I'm going to teach you everything status epilepticus using one piece of paper.
Starting off with the definition, we know that status epilepticus is defined as generalized tonic-clonic seizures that last at least 5 minutes, or if they don't last 5 minutes, but it happens multiple times without regaining consciousness in between the seizures. Now, you can also have focal seizures with impaired awareness that last more than 10 minutes. That means that it's not a full body tonic-clonic shaking type of situation, okay? Now, moving on to treatment options. Obviously, first one is going to be benzos. That's usually our go-to. Remember to not underdose these patients. So for your Ativan, for example, you're going to give 0.1 milligram per kilogram with a max of 4 milligrams, okay? This works 70% of the time, so this is great. Second line, you have a few options. You have Keppra, you have valproic acid, you have phosphorietin, and you also have topiramate. Now, there was a trial that looked at all three of these, and it told us that they are equal at stopping 50% of additional seizures. So one is not better than the other. Usually you'll see Keppra a lot, but again, if you don't have Keppra for whatever reason, or if these ones will also work just as good. And the trial also showed that patients who got both Ativan and a second-line medication had 25% intubation rate. Okay, so decrease the intubation rate for these patients. Moving on to third line, we have propofol, pentobarbital, and then Versed. Drip. Your last resort is ketamine. Let me tell you, ketamine I have seen work wonders, baby. Use inhaled anesthetics. You can use a ketogenic diet. Obviously, all these patients should be on a 24-hour EEG. Okay, these patients need, all status epilepticus patients need to be on 24-hour EEG. If you do not have continuous EEG at your facility, these patients need to be transferred somewhere that there is. And when you start weaning them off of these medications, it's be done under the EEG guidance. So as far as recommendation for how fast or how to wean, there isn't really one. Obviously, you're going to have neurology consulted on these patients. That's kind of a no-brainer. Now, once you've kind of stabilized your patient, you're going to have to think about, okay, why is this patient having seizures? Are they hypoglycemic? Is there an electrolyte abnormality? So get labs, check a glucose, like this one, the glucose, you need to do that ASAP as soon as you see the patient. Are they hyperthermic? Do they have a anoxic brain injury? Check an pneumonia. Is this an intracranial process? You're going to need to get a CT, HAT, or MRI. If you're worried for any sort of infection, consider a lumbar puncture. Eutox, alcohol level, they withdrawing. Are they withdrawing from any other drugs? Obviously, think about your autoimmune, so lupus or autoimmune encephalitis, vasculitis panel, and then PRES can also cause seizures.